first question I've got here, someone asking about light sensitivity, and says that their condition they feel greatly improves while on sunshine holidays. I take it we mean holidays outside of Northern Ireland by that. And the question is, are there any negative side effects to being out in the sun? I suppose that relates to, both to photosensitivity and to vitamin D. As we've heard, everyone with lupus is different. Some patients are very photosensitive, and even on a bright day like that could come out in a rash. Other patients with lupus don't seem to be particularly photosensitive, and I have heard patients say that yes, they can go on sunshine holidays and feel great afterwards. As regards advice, I would say if you have lupus, then yes, you should wear high factor sunblock, probably at least factor 50, whether or not you have photosensitivity. Are there negative effects to being out in the sun? Well, you both boost your vitamin D levels. There is some evidence that patients with lupus, as far as I know, are at increased risk of cancer, particularly maybe skin cancers. So there would be standard advice about using high factor sunblock, avoiding midday sunshine, wearing a hat, covering up. But in general, I would say if you don't have photosensitivity, wear a high factor sunblock, cover up, and enjoy your sunshine holidays. It's just nice to get out to Northern Ireland over the summer. Shall I answer one more here? Do you think they're fed up listening to me?
So we have there's a question here about a cluster of lupus. I'll not say the geographical location, but there is this question about, are there environmental triggers that might drive lupus? So that's an interesting question, because we talk a lot about the genetics of lupus, and that lupus has got a very strong genetic background to it. But you need some kind of environmental hits, if you like, to sort of drive the risk on further. So for example, if you think about sort of lupus, getting lupus is almost like having a deck of cards dealt to you. You're dealt a bunch of cards as a baby or as an infant, and that's the genes that you inherit from your family. And some of those genes will say you will be autoimmune, and some of them will say in the right circumstances you might get lupus. Of course, some of those autoimmune genes might also say, well, in the right circumstances you'll get thyroid problems or rheumatoid arthritis as well. But you're born with that hand of genes. But then as you go through life, things you get exposed to probably affect the risk as well. So in women, once you begin to menstruate and your estrogen hormones go up a little bit, that probably pushes you a little bit further. There's evidence that Epstein-Barr virus, very common glandular fever virus, we virtually all have it, but that probably pushes your B cells up a little bit further. But when it comes to environmental clusters, there have been some clusters of lupus around the world, so around asbestos mines, around some silica mines, etc. And there is some evidence that some of these either soil types or dusts or things like that people are exposed to might have an influence. So some of the areas that are of interest include things like silica. There was work done in Carolina that showed that people who were born in an agricultural background, particularly where there's sandy soil with high silica content, were at a slightly higher risk of lupus than people born in urban areas. Women who were cleaning ladies, who used a lot of scouring cream, they have that's particulate silica as well. So it is possible that there may be small clusters of lupus around the place. But equally, there's also a possibility that if you've got a very, very good GP and a very good rheumatology department in a particular area, that there may seem to be more lupus in an area as well. So this is where epidemiologists get involved to see, is it a true cluster? And then if so, what might be the environmental things around that area? I can't comment on the particular area that was mentioned, but that would be the kind of thing that some people are interested in doing.
Okay, thank you. A question here, could I expand on the implications of long-term PPI use? I presume this is the proton pump inhibitors and not the insurance for mortgages. This is something, there's been evidence which showed that patients who take proton pump inhibitors, and those are drugs like omeprazole, lansoprazole, pantoprazole, drugs which are prescribed often to lower acid levels in the stomach. Patients who take those in the longer term have reduced bone density and might be at an increased risk of fracture. It's an area where you have to be careful, because often patients who are prescribed PPIs, they will be prescribed them because, for example, they're being prescribed steroid as well. And it's difficult to tease out what is purely caused by the PPI and what is caused by other factors, such as taking steroid. It seems once you remove all those other things, there still is a slight link to taking omeprazole and lansoprazole with poor bone health. And it seems to be that it reduces the absorption of calcium and possibly vitamin D. In general, I would say if you're taking, there are some things you can change and there's some things you can't change. And if you're taking steroid or anti-inflammatories, if you've had a stomach ulcer, if you've had a duodenal ulcer, if you've had a lot of problems with severe dyspepsia, heartburn, then you probably need to be on your omeprazole or your lansoprazole. I wouldn't stop it simply because I was worried about the effect of osteoporosis. It may contribute a little to your risk of developing osteoporosis. Therefore, if you're on it for no good reason, perhaps you should be off it. But if you're on it for a good reason, there are other things which will increase your risk of osteoporosis a lot more, and other things that you could do. For example, improving your vitamin D intake, improving your calcium intake. So overall, I would say if there's no good reason to be on omeprazole or lansoprazole, fine, ask your doctor about stopping it. But generally, if you're on it for a good reason, then you're on it. It may contribute a little to your risk of developing osteoporosis, but it won't be absolutely huge. And it may be one of those things, there's not a lot we can do about it.
So, I'm not going to read this whole question out, but I think the question is, essentially, in a nutshell, how do you handle asymptomatic proteinuria in someone with lupus? So that's the broad context. So one of the things that's important about kidney involvement in lupus is it's quite silent. If you get arthritis, your joints hurt. If you get a rash, it's pretty obvious that you get a rash. If you get kidney involvement, it can be very subtle. You can feel absolutely fine. And what your nurse and doctor does when you come to clinic is they dipstick your urine and they look for any signs of protein or blood or red cells or white cells in your urine. And those are actually very, very important tests to get done, particularly early in disease, but all the way through. You can be surprised because people can develop kidney involvement at any point. So if someone has a dipstick that shows protein in the urine and they don't have an infection and they're not on their period, then we would measure, there's a simple test you can do called the protein to creatinine ratio, and that basically measures roughly how much protein you're leaking from your kidney. If you're leaking above a certain amount and you're not known to have kidney disease before, and this is the first time this has happened, if it's persistent over a short period of time on a couple of visits, very quickly apart from each other, we would then ask a kidney specialist to see you, to evaluate the amount of proteinuria you have, and we would be pushing very hard to get a renal biopsy if possible. And the reason we do kidney biopsies a lot in patients with lupus who've got proteinuria at a significant level is because you can't tell from the proteinuria itself or what's in the urine what kind of kidney involvement they have. And different kinds of kidney involvement need different types of treatment to manage them well. So we have a very low threshold for getting kidney biopsies organised, and that helps guide your treatment, because for some things you need less aggressive treatment than others. But what you don't want, and there's been numbers of studies showing this, is that one of the best predictors of poor outcomes in kidney disease and lupus is delays in kidney biopsies. So years ago, people used to have what was called a watch and wait policy. They'd give you a bit of steroid, they'd see what happened to your proteinuria. Then after a couple of years, if it was still there, they would do a kidney biopsy. And then often the kidney biopsy shows some scarring and the damage is beginning to be developed. In recent years, rheumatologists and nephrologists have started to do kidney biopsies much, much quicker and have a much lower threshold for doing them, because you cannot decide treatment without a biopsy. In fact, many people repeat biopsies after a couple of years as well if things aren't settling down. and you'll often be surprised that the biopsy features change over maybe a couple of years. So in the first instance, could this be kidney involvement? A renal biopsy might be the only way to resolve that, and doing it promptly often gets people onto the right kind of therapy.
Okay, another question here about osteoporosis, and this is one I've asked quite a bit. It says, at what age should you be tested for osteoporosis? As every time I ask, I am told that I am too young. I think this raises the question of when a test, or when a screening test particularly, is useful. And it's useful when, if it's positive, then that's useful, and if it's negative, you can certainly say to someone, well, that's okay, you can relax, it's negative. Doing the test for osteoporosis, which is generally a DEXA scan, if you do it when you're too young, it's not really that useful in telling those who are at risk of bad osteoporosis and those who aren't. You remember the graph I showed that your bone density increases to the age of about 25 and then stays fairly level up to the age of about 50. I don't know the age of the writer here, but I'm guessing it's someone who's premenopausal. At that level, whether you've fallen a little below the line or a lot below the line, it won't really show up that clearly on the DEXA scan. And therefore, if you haven't fractured, I would say to you, what you really need to do is simply keep your calcium and vitamin D levels high, stop smoking, do all the other things we've advised. And generally, we don't do a DEXA scan until after the menopause because it doesn't really show up until after the menopause. I would say if you have fractured something, if you've collapsed a vertebra in your 30s, if you've broken a wrist in your 30s, well, yes, at that stage, I probably would do a bone density scan because that suggests that you have fallen quite a bit below the line, and it probably would show up at that stage. But if you haven't actually broken something, even if your bone health is not as good as it might be, it probably won't show up very clearly because you won't have fallen that far below the line at that stage. And a DEXA scan, a bone density scan, does involve a certain amount of radiation, not an awful lot, but we want to avoid giving radiation if we can avoid it, particularly if the information we get from it isn't going to be that helpful in advising you what to do. So I would say to whoever's asked that, if you have actually broken a bone, then yes, please do go and insist you get a DEXA scan. If you haven't broken a bone yet, it's probably not going to tell us very much other than you should take the advice we've already given you.
Okay, so there's a question here about Plaquenil or hydroxychloroquine and whether you can disentangle, if somebody gets an eye problem like macular degeneration, can you tell that apart from potential Plaquenil effects on the eye? So just a bit of background on this. So Plaquenil, hydroxychloroquine, as you know, is an antimalarial drug, very, very effective and very good for lupus. It basically calms lupus down over a long period of time, prevents flare-ups, and it's got lots of benefits. So there's a very strong sort of view amongst rheumatologists that patients, if there's no reason they can't be on hydroxychloroquine, it would be a good thing for them to be on a low dose of hydroxychloroquine long-term to maintain stability of their lupus. The one thing that comes out in the long term that people worry about a little bit is whether it can build up and cause problems at the back of the eye, and there's a particular problem that you get with Plaquenil long-term in the back of the eye. Although it is a particular problem, it's actually quite uncommon. But after about 10 years of continuous use, maybe 2 to 5% of people may begin to get that problem in the eye. So that's why we recommend that people get an eye check every year, get their optician to check their visual fields and colour vision and stuff, because if they find any subtle changes, we would send them to an ophthalmologist. Now, about 10 years ago, ophthalmologists would say if you develop something like macular degeneration, or if you had diabetic eye disease or something like that, if you had a deterioration in your eye on Plaquenil, they wouldn't be able to tell the two apart, so therefore it may be safer not to go on to hydroxychloroquine or continue on it. Now they've got very, very sophisticated machinery in most eye hospitals like Belfast and Manchester and stuff like that. There's a thing called an OCT machine, which actually can measure the buildup of hydroxychloroquine, and they can tell apart hydroxychloroquine problems much better from everything else. And so what I would do is I would, if it was my patient, I would be asking the ophthalmologist, can you tell this apart from another problem in the eye, and is it reasonable for us to continue this drug because of the benefit that it may be producing? If they say absolutely it's not a problem, this is just an age-related thing, and just continue on the drug, that's fine. But if they can't, then we would stop it. The flip side also is that there's a lot, we can vary the dose of hydroxychloroquine. So we try and keep people on the lowest dose that's possible to maintain their symptoms well. So in my clinic, we've got people who are taking a hydroxychloroquine tablet maybe 3 days a week, 200 milligrams 3 days a week, or maybe sort of Monday, Wednesday, Friday, or Monday to Friday only with the weekend off. Because the half-life of the drug is so long. I mean, it's 36 hours. It's a huge long half-life. So even on the 2 days that you're not taking it, it doesn't drop out of your system. The total level just drops down a little bit. So that can maintain people very well. And it's probably the total amount over time that's part of the risk of ocular toxicity. So the less you have over time, the better. So there used to be a vote for just giving people 400 milligrams a day and just keeping them on that. That's not a good idea. You want to try and reduce the dose, keep it within what's recommended for their body weight, and then just pick away at the dose to the lowest dose that can maintain people well.